Hello and welcome. My name is Carol Goodman and I'm the consultant nurse at the Scottish Photodynamic Therapy Centre in Ninewas Hospital in Dundee. I'm going to talk to you a little bit about the centre and give you an overview of the work that we do here. I started working here in 2000, setting up the early version of the virtual centre, and by that I mean that there's no actual building, which is the Scottish PDT Centre. We actually are integrated within the hospital itself. It was officially opened in 2001 by Princess Alexandra and is one of 3 centres, being UCLH in London, Go Hospital, but this is the only centre that's fully multidisciplinary and is the only one in Scotland. We're also European PDT Centre, an honour bestowed upon us in 2015. We performed around 12,000 treatments, a bit more than it says there, on Scottish patients with cancer or precancerous conditions, and also some visitors from abroad that have come here to share in our expertise. We provide photodynamic diagnosis, that's what PDD is, and photodynamic therapy, or PDT, in skin, lung and brain, and diagnostic procedures in the urological cancers, and treat precancerous lesions as well. So let's talk a little bit about how PDT actually works. So we need some components to make it work. This is a photosensitizer. That can either be a drug that you swallow, that's applied topically to the skin, that's injected into the bloodstream or is injected into the bladder. You require red wavelength light that can either be a lamp, a laser, or within daylight. You require oxygen, target tissue, which of course is attached to the patient, and this produces a reaction which we call photodynamic therapy, where the cells that have the cancer or the precancerous lesions are destroyed by the light and the sensitivity. We perform procedures in the skin, in the lung, in the brain, and up until recently we were doing some bladder and ureter diagnostic procedures as part of a trial. That now has moved over to Fife. We're hoping to continue that work with Mr. Greg Catta, who's a consultant who's moved over there. So let's look at a little bit more detail in the brain. So in the brain, we used to do photodynamic therapy, but we stopped doing that as it was part of a trial and the consultant eventually moved on to another place. This happens quite a lot. So we do have surgeons who come and work here with us for a number of years and then they move on elsewhere in the hospital or in other hospitals. So we use a drug here, it's called glialin, and that's a photosensitizing drug that we talked about earlier on. It's 5-aminolevulinic acid, and the patients will swallow this in a drink with some orange juice a couple of hours before the anaesthetic. And then the doctor will remove part of the skull and then shine some light on to the patient with white light using a microscope to try and visualize the area of the brain, and then some blue light to then visualize the tumor specifically. We've performed around 610 of these since 2001, both in photodynamic therapy and photodynamic detection and diagnosis. So we average around about 10 cases of photodynamic diagnosis a year. Now you can see really well here that this is the procedure we now do, which is called a fluorescence guided resection. And these are on really grade 4 glioblastoma multiform tumours, very aggressive tumours. Patients here will have the tumour removed normally, and then it would come back 6 months later or a year later. So our purpose is to try and assist the resection of the tumour so that it's taking away as much of the tumour as possible. Obviously, doctors who are working on these patients are really very careful about how much they remove because they want to leave the patient able to function afterwards. And so there's a fine line between removing tissue, too much tissue, or just enough tissue. And this definitely assists that. So the neurosurgeon here on the left-hand side is using an operating microscope, and down that he can see this area of the brain, and in amongst that brain is bits of tumour. Very difficult to tell what is what. If you look to the right-hand side of that picture, you can see that having swallowed the glialin several hours earlier, the brain here is beginning to glow when we shine some blue light at it. And this is perfect because it allows the surgeon then to remove these pink areas and keep doing this until there are no pink areas visible. Then again, you see down below another patient with similar type of tumour, and here, very different look to it, very difficult to tell what's tumour and what is brain tissue, but when we shine the blue light on the right-hand side, you can see here the tumour is glowing, and that enables the surgeon to remove that. In the bladder, we used it as also a photodiagnostic imaging aid. And here you can see what could be a tumour, but could also be a kind of cyst. But the patient had some similar to glialin, but a slightly different medication called Hexvix, which is licensed for the bladder. And this was injected into the patient through a catheter. And you can see here that the white light shows this little sort of squiggle, but if we shine blue light on it, that's taken up the drug and it's glowing nicely. So the surgeon in this case, using a little telescope called a cystoscope inside the bladder, would then use a bit of electrocautery and diathermy and burn that and scoop that off and take the tissue and send it away for biopsy to confirm what it might be. So really the photodiagnosis in the bladder and upper urinary tract was carried out very successfully from 2000 to 2017 initially, and then our lead clinician, Greg Catta, joined us then, and he continued with doing these and also some active research in photodiagnostics, including in the upper ureter. And these are the little tubes that go from the kidney down to the bladder. And if you get tumour in those and it blocks those, it can actually damage the kidney. So the purpose of this research is to enable us to identify the tumour in the ureter. Once that's done, it could be safely removed and therefore preserving the kidney. I would say that here, one of the most important things, and we have technicians and nurses who work in the centre, all who perform treatments here, obviously mostly in dermatology, and assist the surgeons with the lasers and light sources for their other procedures. But counselling and supporting of our patients is really second only to any treatment, because we have to explain thoroughly and advise patients, take care of them and make sure that they know what to expect, have realistic expectations of any of the outcomes of any of the treatments. You know, some of these are curative, it's mostly palliative, and in some cases it's chronic conditions, especially in dermatology, where the patient will come back again and again for treatment to different areas for their chronic conditions. So we have to know and be able to explain the objectives of the treatment to them as well, and make sure that their relatives also are informed of what's happening with them if they're accompanying them. It tends to be a slightly older population that we treat. In dermatology, we can see here some of the light sources that we use. So these are red wavelength lamps and light sources. In dermatology, I think I said earlier that we do PDT, photodynamic therapy, in superficial non-melanoma skin cancers. So these are the non-mole type skin cancers, so superficial basal cell carcinomas, and we treat precancerous lesions like Bowen's disease and another condition which is sun damage called actinic keratosis. And we use daylight PDT for this, and I'll talk about this shortly. So in skin PDT, our sensitizer is slightly different. It is a cream, and we have two types that we use. One's called Metvix and the other one is Ameluz. And they actually are prodrugs, we call them, because what they do is they produce, they're inactive, but they produce a chemical when the light is shone on them, and that then will cause the reaction earlier on we talked about, which is the apoptosis, or the death of the cells, the targeting cells. So you can see white light here on the left-hand side showing this tumour, and then the blue light after a few hours of showing the application of the cream and how it's absorbed specifically into that lesion. Then the patient would either have a red lamp shone at it, or if it were an actinic keratotic lesion, they would go outside and absorb the red wavelength in the sun. So these patients are generally, although elderly, are well and have these skin cancers or precancerous lesions. So we'll talk again about daylight PDT just in a moment or two, but they did some studies here called ambulatory PDT, where they made these light sources and used it for Bowen's disease, which can change into a slightly more serious type of skin cancer called squamous cell cancer. Later on, I think the physics team will talk to you a little bit more about that. So for daylight PDT, we need several things. Again, PDT, you require a few different things to make it work. So the first thing that we require is sunscreen application on these patients that we treat. So these are patients who have this condition called actinic keratosis. It's a very common condition in the elderly population or older population from people who have exposed during their lifetime themselves to a lot of sunlight and had sunburn and sun damage. So we make sure we put on a lot of sun lotion when we're doing this treatment to protect them against any further damage. We prepare the surface area, and it's often a large field area. So in this case, it may be a forehead, a head, a scalp, a face, neck, hands and arms, and even legs. We then apply the creams, and then we send them outside 45 minutes later to sit outside, walk outside, or enjoy themselves generally outside in the sunshine for 2.5 hours. So we'll go on to it in a wee bit more detail. So as we said, we want to put on sun protection here. We don't want them to end up getting further sun damage. So we apply a 50+ lotion all over all the areas that will be exposed, especially around the ears, the face and neck, hands and arms. After that, we use a little device called acuratage, which is just a scraping gently of the tissue to try and let the cream absorb a little better. After that, we talked about the prodrug, so we'll either use Ameluz or Metvix. It's a random choice that patients are given in each group, are told which one they're going to get. Both work equally well. And we reinforce with them that they have to go outside within 45 minutes of this being applied and stay outside for about 2.5 hours. So we'll talk about that later on in a specific talk, but I just want to say that we continue to offer really state-of-the-art treatments and diagnostic procedures and cutting-edge research here. It's all provided really because of the fantastic support of the Alfred Stewart Trust, which is a charity that's been supporting us for the last 20 years, and also the NHS as well, who also support the centre. And here's our team with our clinical director, Professor Sally Ibbotson. And as I said to you, we really want to thank all those that collaborate with us. And Medilays is our little charity as well. And the Clinical Research Centre, the University of Dundee, Innovate UK, and this British Skin Foundation. So all of these companies support and help us. Thank you for watching.